Welcome to a brand new explainer. So picture this. You're in the ER. A patient's life is literally on the line. How do you make the right call? Well, you don't just guess, right? You have to become a medical detective. Today, we're popping open the ultimate investigative toolkit used by the best doctors around the world, and we're going to see exactly how raw data gets transformed into life-saving decisions.
Okay, let's dive into this. It's super easy to think that medicine is just, a bunch of memorized facts. But in reality, human intuition is incredibly vulnerable to bias. Our minds play tricks on us all the time. So, to defeat that bias, modern medicine relies on a really rigorous, bulletproof system known as evidence-based medicine, or EBM. It's basically the ultimate detective toolkit, specifically designed to separate real medical truth from well-intentioned fiction.
Here's how our clinical journey is going to play out today. First, asking the right question. Second, appraising diagnostic test accuracy. Then, evaluating therapeutic clinical trials, assessing prognosis and harm, evidence synthesis, and finally, a summary of key takeaways.
All right, Section 1, asking the right question, formulating search strategies. Let's get into it.
Picture a doctor facing a really complex patient dilemma. Before they can even find the answer, they have to know what to look for. Evidence-based medicine isn't just about flipping open a textbook, it's a highly systematic methodology. EBM is actually this perfect intersection of three things: the doctor's own clinical expertise, the unique values of the patient sitting right in front of them, and the rigorous mathematical appraisal of scientific evidence. Because, at its core, medicine really is a deeply mathematical science.
So, the crucial point here is how we actually start that search. Enter the PICO framework. Think of this as the digital compass doctors use to navigate an absolute ocean of data. Instead of just randomly Googling a disease, you explicitly define the patient population, the specific intervention you want to try, the comparison, like a placebo or standard care, and the clinical outcome you're hoping to measure. Whether you're looking at therapy, diagnosis, prognosis, or harm, PICO structures that inquiry perfectly.
With our PICO compass fully calibrated, we hit the databases. And no, doctors aren't just using Google for this. They hunt down data across specialized platforms, like PubMed, the Cochrane Library, which is fantastic for top-tier systematic reviews, and Embase for really deep pharmacological data. And to filter out the noise, they use medical subject headings, or mesh terms, along with Boolean operators, which are just your classic and, or, and not commands. These tools basically act as a magnifying glass, letting a researcher pinpoint the exact clinical trial they need out of literally millions of published papers.
Section 2, appraising diagnostic test accuracy, interrogating the clues.
This is where we put the medical evidence right on the interrogation table, and we do it using two critical concepts: sensitivity and specificity. A highly sensitive test is absolutely great for ruling out a disease. Just remember the acronym SNOUT. If the test is negative, you can trust that the pathogen just isn't there, which ties right into negative predictive value. On the flip side, specificity rules in a disease. SPIN. If a highly specific test comes back positive, it strongly points to the true positive rate and positive predictive value. Basically, you need both of these tools to trap a diagnosis.
But here is where the math gets genuinely exciting. Tests aren't perfect, right? So doctors use likelihood ratios. A likelihood ratio tells you exactly how much a positive or negative test result shifts the probability that a patient actually has the disease. It takes your initial guess, that's the pretest probability, and mathematically transforms it into a definitive post-test probability. It literally turns these abstract mathematical concepts into a concrete, actionable clinical diagnosis right at the bedside.
Now, all of this relies on Bayes' theorem, which basically reminds us that a test's accuracy heavily depends on the underlying prevalence of the disease in the population. We actually map out this accuracy using receiver operating characteristic, or ROC curves. But a massive warning here for our medical detectives: you absolutely must beware of spectrum bias. If a diagnostic test was only studied on the absolute sickest patients, well, it might look incredibly accurate on paper, but it could completely derail your real-world investigation when you try to use it on someone with only mild symptoms.
Okay, moving to Section 3, evaluating therapeutic clinical trials, finding the cure.
When we step onto the battleground of randomized controlled trials, we are completely flooded with metrics. You've got relative risk, odds ratios, and hazard ratios for survival data. But you really want to focus your attention on absolute risk reduction. This is the actual real-world difference in risk between the group that got the drug and the group that got the placebo. And why is this the holy grail? Because it determines the number needed to treat, or an NT.
The NNT tells a doctor exactly how many patients they need to give this drug to in order to save just one single life. It's incredibly powerful.
Now, what's really interesting here is how we analyze the patients in these trials. We look at intention to treat versus per protocol analysis. Intention to treat keeps every single patient in the group they were originally assigned to, even if they straight up quit taking the medication. Why would we do that? Well, because in the real world, patients forget their pills. It preserves real-world validity. Per protocol, on the other hand, only looks at the perfect patients who followed all the rules. So intention to treat is really your ultimate safeguard against biased researchers trying to hide the fact that the therapy failed out in the real world.
And sometimes one trial just isn't enough. We have to look at the meta level. Systematic reviews pull together all the high-quality randomized trials, and then a meta-analysis uses some pretty heavy mathematics to combine all their data into one massive conclusion. When you look at the visual representation of this, which is called a forest plot, you are essentially looking at the Supreme Court of medical evidence. It resolves conflicting data from single studies and hands down the absolute final verdict on whether a treatment truly works.
Section 4. Assessing Prognosis and Harm, Mapping the Future.
Pivoting to the slightly darker side of medicine for a moment, we use cohort studies to understand long-term prognosis and toxic harms. Imagine tracking a patient timeline, plotting it all out over, say, 60 months. Along the way, we're tracking outcomes and really carefully watching for confounding variables. Ultimately, doing all this allows us to compute a Kaplan-Meier survival curve. This curve visually tracks patient survival outcomes over time, which helps doctors calculate the attributable risk and the true population impact of a disease or maybe a harmful exposure. But calculating survival? It isn't simple. It requires advanced statistics like the Cox proportional hazards model. I like to think of this regression model as the ultimate polygraph test for observational data, especially in case-control studies. It looks at several risk factors simultaneously while strictly controlling for hidden confounding variables. These confounders, they're kind of like hidden accomplices in a medical crime scene, factors that skew the data and make a totally harmless variable look deadly. The Cox model smokes them right out. And all this heavy statistics and survival analysis eventually gets distilled right down into reality through clinical prediction rules. These are incredibly fast, bedside risk stratification tools. Because think about it, when an ER doctor is staring at a crashing patient at 3 a.m., they definitely don't have time to run a complex regression model, right? Instead, they use these validated rules, built on years of cohort data, to instantly decide who is at high risk and needs the ICU and who is safe to just go home.
Section 5. Evidence synthesis, making the final call.
So all of this data ultimately builds into actionable guidelines using the GRADE methodology. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation, and it systematically scores the quality of the evidence. First, you establish initial levels of evidence based on the study design. Then, you downgrade that score if there's a high risk of bias, or you might upgrade it if a treatment shows a massive, undeniable effect size or dose-response gradient. Finally, based entirely on this math, medical societies will issue a definitive, strong, or weak clinical recommendation.
But as pristine as the scientific evidence in that grade score might be, all that math means absolutely nothing if it isn't integrated with the human element. Modern clinical decision-making truly requires shared decision-making. We absolutely must integrate the hard science with what the patient actually values and desires for their own life, while also factoring in health economics and cost-effectiveness. It's a really delicate three-part balance.
Which brings us to Section 6, Summary of Key Takeaways.
Okay, let's do a rapid-fire review of this phenomenal detectives toolkit we've just unpacked. Here's your definitive EBM checklist. We use PICO to flawlessly structure our searches across PubMed and Cochrane. Remember SNOUT and SPIN. Sensitivity rules out, specificity rules in. In therapeutic trials, you always want to verify the intention to treat analysis to avoid bias. For assessing harm and prognosis, we lean on Kaplan-Meier curves and Cox models. You synthesize it all with the GRADE methodology, and never forget that true evidence-based medicine always ends with shared decision-making right at the bedside.
We've seen how meticulously doctors filter out bias to find the actual truth. But I'll leave you with this one thought. As artificial intelligence and machine learning get exponentially smarter at processing this exact kind of data, will these algorithms eventually replace the human EBM detective entirely? Or will they simply become the most powerful magnifying glass in our clinical toolkit? It's a really fascinating frontier to watch. Thank you so much for joining me on this explainer, and keep asking the right questions.